Alrighty, welcome everybody. On behalf of the Florida Department of Health in Volusia County, welcome to the 2021 Path for Hope Virtual Summit. You've joined the Stigma Interactive Discussion for general audiences. My name is Jordan Holly, and I'll be facilitating this session. I would like to welcome Sarah Bacon, who will be the subject matter expert for this session. Please keep your microphones on mute until you're recognized to speak. You can raise your hand to be recognized and to participate in the discussion. You can also submit any questions or comments in the chat feature, and I'll read them aloud. You are invited to turn your cameras on for the session. And I want to thank the Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and the Volusia Recovery Alliance. I do have several questions to promote discussion, but we will follow the conversation where it kind of takes us as we're talking. And I would like to start with just the first question to get the conversation kind of going and started. So, what are some examples of stigma regarding substance use?
Thanks, Jordan. And hey, everyone, thank you so much for joining. I fully respect the realities of Zoom and camera fatigue. So keep your cameras off if you're comfortable. But I also, as Jordan said, invite anyone to turn them on at any point. It's always nice to see faces associated with the names on my screen. This is such an important question, such an important conversation. And I also, as you know, I will share my thoughts, but also I'm really curious to hear from a lot of you. Because of my role at CDC, we sort of study stigma and recognize the role that it plays in disrupting our efforts at prevention and treatment and health promotion. But I suspect most of you have much more kind of visceral and real experiences with it in the work that you do. So I'd love for this to be a conversation. The way I see stigma playing out, particularly with respect to substance use, I think, of course, first and foremost, everyone is painfully familiar with the really kind of still prevailing notion that substance use and misuse is a moral failing somehow, or a deficit of character, or in other ways, some sort of weakness or individual personal failing. And that really plays itself out in pretty insidious ways. I think in particular with respect to substance use, people will then say, well, there's all of these behaviors associated with the disease of addiction that really are harmful. And that is true, but the same could be said of some of the behaviors that may be associated with chronic pain or with diabetes or heart disease or any of the other sort of physical ailments that we don't assign the same sort of moral value to. And so I think, pretty consistently, that's the first prevalent form of stigma that we encounter. The way I see it playing out often is, we do a lot of work at CDC with healthcare systems and more of the institutions and organizations that do service provision or, work in some capacity with respect to prevention and treatment. And it continues to shock me when I see providers and clinicians and people who are, in a professional role of supporting people toward better versions of health, that they still hold some of these ideas about the disease of addiction is a moral failing and a choice. That's really disruptive. And at a systems level, what we see happening is fewer providers offering this sort of trauma-informed care and this sort of treatment flexibility and options that we need to be able to offer to people that are struggling with substance use and misuse. The other thing that I think we've seen more recently, particularly as the opioid epidemic kind of came more and more to the public consciousness, is a stigma associated even with help-seeking behaviors for the disease of addiction. And I'm thinking here in particular of medication-assisted treatment. You know, and persistent ideas that that's just sort of replacing one substance for another, enabling a different form of substance dependence, et cetera. And we continue to see that even within healthcare settings and systems as well. So a lot of work to do on this front. The other thing that's related, and the last thing I want to mention before I would love to turn the question back to any of you of how and where you see stigma disrupting our efforts and really being a barrier to the work that we do. But I want to talk for a minute about adverse childhood experiences, which is really where I spend a lot of my time. It's ACEs, as we call them, are really inextricably related with substance use. But there's a stigma that's associated sort of with ACEs themselves. And that is that there's this sort of narrative that child abuse and neglect in particular are the result of bad people and bad parents. And that's just not a helpful narrative. That's a form of stigma that really gets in the way of our ability to address the system drivers and the institutional realities that can make child abuse and neglect more likely. It's not just a bad parenting or a bad person issue. It's a matter of putting systems in place to support parents, to support families, to give them the resources that they need to navigate the stresses and the challenges that we all face. And really sort of turning that lens from being one of pointing the finger and blaming parents to assuming some more community and societal level responsibility for creating the conditions that would allow children and families to thrive. That's something I see a lot in the context of ACEs, but I think it's also really, really relevant with respect to substance use as well. So that's sort of a, you know, the lens or the version that I experienced from CDC, but I'd love to hear from any of you sort of what stigma looks like for you in your daily work, or put a finer point on any of that I've just shared. And I think it works if you will raise your hand.
Yeah.
Tracy can then unmute you so you could share.
Thank you so much, Sarah. And yes, absolutely. Raise your hand or put anything in the chat and we'll allow you to unmute yourself.
I see Lynn has a hand raised.
Good morning. Thank you so much for that overall introduction. I would like to talk just a little about the language. I think the language is changing and rapidly for the better, but it's something that people who are, whether they're in the field or not, have a recognition of which things are kind of triggers, so to speak, indicating stigma. Can you say a little bit about that?
Sure, and I would love to hear your thoughts too, because I, you know, as someone, I'm usually a bit behind practice in terms of the language. I think we have been very careful to, you know, use language about the disease of addiction. To me is a very important one, and sort of stubbornly talking about it as a disease, because I think even in just very subtle ways, that sort of is a consistent and persistent chipping away at that idea that addiction is something other than a disease, right? That it is a moral failing or a personality flaw or something like that. So talking about the disease of addiction, talking using sort of people and person-centered language. So people who it was a term a lot of us, I certainly used without a lot of critical reflection on how much was packed into that. Like there's a lot of stigma and blame really implicitly packed into that one word that can actually cause a lot of harm. And we do this across public health, you know, with respect to people experiencing homelessness, for example. Or, you know, with respect to, I'm trying to think of other examples of just that person-centered language. I think we're doing a better job of it.
Yes.
But I will say that this is really where organizations like CDC and a lot of other federal or just government agencies really rely on the field. We rely on people in practice that are much, much closer to the applied versions of this work to let us know, and then we can help sort of broadcast and disseminate, but it really depends on us listening to all of you. So Lynn, I would love to hear what your experience has been, and sort of, if you have any that still trip you up, which I think happens, and as a field, we have to support each other and extending grace to kind of know better and do better.
Yes, that extending grace, that's a good phrase. I struggle a little bit with substance use and substance abuse, because substance abuse has been the language for so long that we're moving to substance use, and so, or misuse. Sometimes I see that with the parentheses in front of it with the misuse. So that one has been a little bit for me, but I'm learning constantly. And I think without the voices of people with lived experience, I don't think we continue to learn. So I'm really happy to see more of that happening, where we have people with lived experience, people whose families and friends have had direct impact on their lives. That is really helping us to change the language and to know where to go with the language, because that's what's informing us, I believe. So thank you.
Thank you for raising the issue about substance use, misuse, abuse. That's one where, frankly, it's still a really dynamic conversation for us within the Injury Center at CDC, in particular, because there are those who feel that misuse is only appropriate when you're talking about prescription drugs, because there is an appropriate use and then there's a misuse. Some feel that the term that substance use is not inherently problematic, right? I mean, if I take my regular medication every morning to manage some condition, that is substance use, right? But certainly it's not pathological or problematic, or, the term substance use, could it just be descriptive? But then abuse is potentially overly stigmatizing. I'd love to hear from some of you, your thoughts on that, or how much, if you've had discussions and landed on any good solution, because I think we're still sort of navigating some tricky waters, and it's context always matters so much with respect to that language in particular. Are there others who have thoughts you can share?
We did have Vanessa raise her hand.
I do have a comment. It's not about this, but one thing I think is really innovative that's happening at the national level is for syndromic surveillance. And I think so we haven't really accomplished necessarily tracking like social determinants of health. And of course, stigma is a main determinant of health. And I think one thing that's amazing that's really happening, conversations have started, and we've really began to test out a couple of different queries for tracking stigma in syndromic surveillance as it relates to like weight, body weight, and body weight stigma. But I think that they're trying to develop a model that would be able to be applied ultimately to any type of stigma. And I just really wanted to mention that because I think it's so awesome. And we have qualitative data. We know that stigma is happening. But I think really also seeing that quantitative data would be awesome too.
Yeah, Vanessa, thank you for sharing that. That is really fascinating, because I think so often, we think of stigma as sort of this softer, squishier side of what could be measured. And, we like our very quantitative, quantifiable outcomes. And so to attach some quantitative data with stigma is a really cool innovation. And I'm guessing that's something to do with like natural language processing kind of algorithms applied to the syndromic data. Is that
yeah,
okay?
Exactly. A lot of like specific keywords in medical charting. We're really just starting out, but we're looking at a lot of like books that have been published on like the cultural experience of stigma as it relates to like body weight and things like that. So we're really just kind of trying to pick out those like key body shaming words that people typically use, even just like clinical words like, obese or things like that. But just hopefully that definition will be able to kind of be applied in a model to substance use stigma. I know that's going to be hopefully the second project. Several of us are interested in working on that as well.
That's very exciting. And, related to Lynn's point, I think we have no shortage of the words you could query to look for that kind of substance use stigma, because there's a lot of language that's still in really heavy rotation and not, really critically assessed by a lot of people that are very close to the field and doing this work. So I'm afraid you'll find no shortage of stigma emerging when you do get to that, the analysis as it relates to substance use and misuse. Thanks for sharing that.
Thank you.
We also had, and excuse me if I pronounce your name wrong, Nalini raise her hand.
No, I'm sorry, I didn't raise my hand.
Oh, sorry.
Other thoughts though on, I really would love to hear from y'all particular, and truly because this is still on my to-do list sort of in my professional existence of, whether with respect to substance use, misuse, abuse, what are the parameters that you all have thought through for yourselves in your work? Or what's some other either problematic language or just different ways that you see stigma emerging in the work that you do or that you've experienced for yourself?
I'd like to chime in here. I think that, Lynn did point out how it's constantly changing and evolving the terms that we're using. So it can get confusing. Well, what word do I enter here and what word do I enter there? Because I definitely don't ever want to offend a peer or anyone else that I'm working with. And I find that if I keep like that rule of thumb that you had mentioned with the person-centered first language, no matter what word I'm saying, no matter what term I'm using, if I make sure to put person before it, generally that I find that it definitely eliminates some of that stigma. Because there is stigma. I also wanted to add that, there's also stigma for family members of those who are in recovery or need to be in recovery. For example, if someone loses their son or daughter to an overdose, they're not able to grieve the way that a normal death would be grieved, because they're faced with that, that feeling of everybody thinks if I had done better, or or even their own, if I had answered that phone call, so there's a whole lot of stigma just in passing away even, which is just so sad. We did have somebody in the comment, I don't know the name, it's like CHD 45, and and stigmatizing words look different across the age span. Kids interpret more words negatively than some adults would. Absolutely.
That is absolutely true. And just as a funny aside, I recently learned that we are not supposed to be putting periods or punctuation generally in our text people of a certain age. I had no idea. My niece informed me that apparently she thought I've been mad at her for the last 6 months because I put periods in my text to her. And that's a little bit of a lighthearted example of that. But I wonder, this is a really tough one, because I think, for all of our striving and critical assessment of our own language, there are generational differences that, we just sort of don't have access to unless we ask, right? And so I think that's another part of what we can attend to is, creating that space for different generations to reflect actively. I don't know what some of the words or phrases or terms are that would be problematic. So I don't know if folks have examples of those they can put in the chat or share with the group. out loud, because I certainly don't feel in touch with some of the generational gap in language differences. And I think there's some, the other way around. I think some younger generations use language that might be feel abrasive or grating to my older ears. But that's not necessarily the intent of the language. So appreciate that point, because that is very, very important and can be really distancing if we're not careful about navigating those language differences. I'd love to hear too about, and Jordan, I may be kind of jumping ahead to the next question here, but in terms of what do we do? How do we address this? And I think we've already touched on several of the sort of paradigmatic approaches that you can just sort of infuse into your daily work of, using the person-centered language and being critical and flexible with our language, being okay with being told when we get it wrong, and working to do better, and also gently supporting others in learning and then doing better. One of the things, again, from the sort of systems and institutional level that we talk about at CDC are things like social norms campaigns. And these have been so important for all of our work. In Injury Center, we focus on ACEs and suicide and overdose and motor vehicle and traumatic brain injury and older adult falls. So we have a really broad net, but I think in particular, with respect to substance use and substance misuse, you have to be kind of relentless if you really want to change social norms. And I think we still have a lot of work to do on this front, but I do think we have made progress. And to one of the points made earlier with respect to things like obituaries, a lot of you probably know the work of Sam Quinones, who I think has really been a champion of naming overdose in obituaries and taking away that cloud of shame and stigma that would otherwise sort of, just perpetuate really the stigma. I think the same is true of for things like death from suicide. But back to things like social norms campaigns and just really relentlessly infusing the messaging, reaching every audience, general audiences, professional audiences, clinical audiences, behavioral health, mental and emotional health, and health and human services, and schools, law enforcement, justice serving organizations, the business community, really casting a broad net in terms of recognizing that every sector of society can either perpetuate stigma or can be sort of co-opted into efforts to address it. And so really taking a communications and scientific approach to social norms campaigns and tweaking those norms and addressing what for a lot of us is a really unexamined assumption about the causes of substance use or substance initiation or child abuse and neglect and any of these other things we're talking about. So I see a couple of hands raised. I'd love to hear from some of you about what that looks like in your work and what should we be doing to address stigma.
I do believe Lynn's hand was up first. Sorry if I'm wrong.
Oh, I'll be quick. I just wanted to mention you were asking about other forms of stigma other than language. And I have heard from peers and I have heard from presenters over the last 2 days. So I've heard from both sides of the equation that there is a lot of stigma in healthcare, that the healthcare provision, not only attitude, but actually physical handling things differently. So that was really important for me to learn about from both the patient or peer side and from the professional or clinical side.
Absolutely. I think a lot of blaming, patient blaming. And then also, I think it's sort of almost like a form of gaslighting, but not every healthcare need is necessarily associated with the disease of addiction, right? And I think some healthcare providers are quick to dismiss complaints or chalk them up to a side effect or a byproduct of the disease of addiction, when in fact they might be independent and warrant treatment regardless, right? Warrant attention and care regardless of the source. I think that's absolutely true.
We also had Vanessa raise her hand.
I just really love that you mentioned like stigma within our own profession. I'm an epidemiologist, and I think it's also very important in how we frame the data in terms of how this issue has changed over time. Historically, we've framed it as a white male issue. However, minority populations are affected, and all populations are affected. So I think it's just really important to highlight those disproportionate needs rather than concealing them into an issue that only affects one population or one group or one region, because it doesn't, it affects everyone. So yeah, just love that you mentioned that. And Lynn, I loved your comment also about the healthcare profession as well.
Yeah, Vanessa, thanks. That's so important. And I think for me, an area where I've started to appreciate the very limited and frankly kind of institutional racism lens that I have brought to my work was that I was always, I think, mindful about interpreting data through an equity lens, but was not taking adequate consideration of the extent to which the systems by which we gather data are biased themselves, right? Like the systems themselves reflect bias and inequities. So try as you might to sort of bring an equity lens to what you're interpreting, there's an even deeper and more fundamental layer of bias and inequity that's there. So we actually need to fix our entire data systems to accurately reflect the experience of all people. Yeah, so thank you so much for raising that. I think so often it's easy to sort of feel like the data are the data without taking that critical approach.
And then next we had Deja raise their hand.
Hi, so I am I'll start my video so you can guys, hi, okay, hold on. Hi,
There you are. Hi.
I am an opioid prevention coordinator working for the OD2A program at the Department of Health in Clay. And I had the opportunity of experiencing an individual going through the withdrawal process. And I got to go with our paramedicine program, which is our Clay County Fire and Rescue. And we went to St. Vincent's Hospital. We requested a room in the emergency room. And we talked to the client about the whole process. And so she first received her first dose of Narcan, which, immediately starts the withdrawal process. And I can tell you right now, the nurse was not nice. And that's, a great example of stigma. I felt like he was not compassionate enough or empathetic enough to understand what she was going through, because that's seeing her so me, I've never experienced that before. It was very interesting. And for me, it was an emotional experience for me because I never knew what an individual goes through when experiencing withdrawal. And to see the amount of pain she was going through, and the nurse was just like, he didn't really care. And I felt terrible because if I were in her position, how would I feel if I'm not even really welcomed here? Yes, I'm struggling through this, opioid use disorder, but I'm trying, I'm here to make a change, and I don't feel welcomed. And that made me very upset, to be honest. And I feel as if, healthcare workers definitely need to work on trying to be more empathetic towards individuals who are suffering with that disorder.
I think, thank you for sharing that. And thank you for the work that you're doing. I think what you're pointing to is the really important connection between stigma and compassion fatigue.
Mhm.
I think the persistence of stigma across, all of the different sort of professional lenses that might bring people to this work, but I think in particular law enforcement and healthcare, and emergency medical care. Compassion fatigue, I think, is I don't know that it's inevitable. It's certainly common, and certainly sort of a natural. I'm sorry, you all may hear my dog who has spotted a squirrel on the deck and become very agitated behind me, but he'll settle down in a second. When people are experiencing compassion fatigue, it's almost like stigma is there as the hook, and the easy thing to plug in, so they can almost like take refuge in stigma. It becomes a sort of maladaptive coping for the healthcare professional to retreat into that more categorical thinking of like, I don't have to care about this person because they're here because of their own choices and their own fault, right? So it's stigma that sort of gives them that easy out of the compassion fatigue, when instead what we should be doing is thinking about how our systems can support that nurse, can support those people in rendering compassionate care without destroying their own energy and empathy. It is so incredibly difficult, but it has to be that kind of systems level response. Because on the one hand, it's sort of, I wonder how many people that nurse had supported through withdrawal. Probably started from a very different place, and probably was just running on empty, right? Unfortunate that then we, as I think human beings, retreat into stigma because it's this sort of, uncomplicated, easy way out of like, it's their fault anyway. I don't have to care. But let's, as a system, do better so that nurse had other options, other than just detaching and providing what, you're right, was probably a traumatic interaction. I mean, if it clearly affected you, and as you're saying, imagine how it affected this person with a horribly painful disease that was seeking help. And to feel judged in that moment, talk about needing to build a trauma-informed system. We have a lot of work to do on that front.
I would like to add, just because I don't see any hands raised, so I'm going to chime in. There was definitely, I think that we are on our way to at least one solution, and probably many solutions, but one of them being, the peer workforce growing and being able to get out there and be like, this is my lived experience. And like also modeling recovery by doing so and showing that it's possible, but also making sure that that peers are getting out there to those first responders, to the healthcare professionals, and just making sure that, because they constantly see this person overdosed again, this person overdosed again, this person overdosed again. It's draining. But if they can, get some of that hope from the peers going in and, explaining it is a disease, it's not a moral deficiency, but it's a disease that can be managed. And I know this because I have done so. And I know that I recently had an example where I was giving a training, and there was a nurse who works in the NICU, who had worked in the NICU field. And she had explained how some peers had changed her level of stigma on substance exposed newborns and their mothers, because initially she would go to work, and if she had a substance exposed newborn, she would immediately judge the mother, like, why didn't you just stop while you were using? She couldn't understand because she had never dealt with it on a personal level on her own. But through her work and seeing some of the peers that, had a substance exposed newborn story and were able to recover through it and explain to her and, have that dialogue, she now has that compassion that's needed. But if she didn't ever learn it from somebody, you know, it would have never been there to grab in the first place. And I know from personal experience, you know, my son was born substance exposed. Um, and I had my own stigma going on, and you could walk into that NICU and feel the shame and guilt and stigma just by looking at all their faces. And it wasn't conducive to any level of recovery or healing, which caused, you know, my story to go a little bit longer before I got him back. But even when I would go to the doctors, I could feel it, you know, there was never anybody that I could talk to. But then we have doctors in this area like Carbiner who have the understanding, who understand the disease aspect of it, who have that compassion, and they're able to make a real difference and prevent the babies to be born substance exposed just by having that knowledge, you know? Sorry, end of my little rant.
No, thank you, Jordan, so much for sharing that and that part of your story. And I see Arthur's hand, and I want to get to that, but I do want to say, I think you've pointed to something that's so critical, which is the intergenerational nature of trauma and of this work. And you know, it's like you said, there was a missed opportunity to connect with you and bring you closer into a system of support. And instead of that being your experience, you know, you said you already had your own shame, and then you throw stigma on that. That's fuel on a fire. It just it grows so much and in such harmful ways for everyone. And the other thing I want to say in particular, because I do think that, you know, newborns experiencing withdrawal and who were exposed to substances in utero, there, you know, that is definitely one where emotions get really intense and really high. I think it's so critical that we talk about the positive frame of the strength, the positive childhood experience that can be derived from having a parent who is managing their disease with support, right? I think, you know, there's a lot of people who want to talk about neonatal abstinence syndrome or neonatal opioid withdrawal syndrome as an ACE, as an adverse childhood experience. I want to talk about it as the potential for a positive childhood experience, because seeing, you know, having a parent become involved in a network of support, take ownership of their health, you know, be a part of a system that will support them in treating and managing a disease. What an amazing opportunity and lesson for a child. So I think, you know, it's also really important for us to talk about the gifts that can be bestowed on children of parents with the disease of addiction, because the opportunities there are very real. So yeah, thank you for sharing your story and for pointing out that really important opportunity that we have in this work that we're doing. And Arthur, I hope I didn't talk so long that you forgot your point. I know that you had your hand up. Oh, I may have called Arthur out inappropriately, because I think it might have just been my little cursor over Arthur's name. So forgive me, perhaps not. You would think after 18 months of everything being Zoom that I would have it figured out, but I still managed to find some new way to misinterpret the Zoom signals. Does anyone else want to share any, you know, experiences or struggles related to stigma? I see Lynn.
Yes, I don't want to barge into the conversation too much here, but I was impressed with several of our presenters, and I know I'm part of hosting the summit, so that's easy for me to say, but I was just wondering if other people had heard presentations during the past 2 days that were impactful, that as a person involved in this summit and bringing it to you, so to speak, I would be happy to learn about whether there were some instances that were, you know, changing perspectives.
Vanessa, you
Marisol
look-
has her,
oh, good. Marisol.
and then Vanessa.
Hi, I just wanted to say how touching and moving it was for me from the, I don't know, believe it was something to rise to, I forget the title now, but this lady in Jacksonville, how she had this vision of helping, I'll say one particular area, and now she has built this amazing campus where she's helping with everything, even like cooking lessons for the kids and everything, and how just from someone's passion and all that all of you have been mentioning, to have that desire to help somebody, and then you end up helping like so many people, not just with one issue, but so many. And then with all that's being said, on my background, learning prior to coming to OD2A to work with this team, I did not know that it was a disease. So learning that it is, I can better understand, like say my nephews and those ACEs, how important it is and how to break the cycle. So it happened because we went through this trauma, but most likely we went through that trauma because our parents went through that trauma. So how do I now as a parent avoid my kids going through that trauma? So that's very important to me. And thank you all so much, and Lynn and everyone that's worked on the summit. It has been phenomenal and amazing, and I'm just so grateful for everyone that took the time to join us.
Thank you for sharing that. And I noticed that Jordan put that it sounds like it was the Inspire to Rise presentation, was maybe Marisol the name of the one you were looking for.
I have to say, Inspire to Rise is an amazing partner in Jacksonville. Just thank you for mentioning them. They're doing such good work. I feel really lucky to work with them. But a couple of presentations that I attended that I thought were so interesting was the one that Kyle McDonald had on how do they do it up there. It was a Canada comparison to US. It was so cool. Such good information shared there. And also, I work with Mark Rowley occasionally as well. He had a presentation, which I thought was amazing as well. He talked about his personal experience as a paramedic and how his training did include stigma. Like his books literally had the word junkie in them. And I mean, he was trained in the 90s. And so he said like things are a little different now, but like just same with you, Deja. He had an experience where like, you know, he's seeing people who are in withdrawal, but didn't really even understand it until like it actually was more someone he loved and cared about. And that was like his moment of clarity, but definitely amazing summit. Thank you.
It's so critical to have these sort of events and summits and you know, of course, there's sort of the practical aspect of learning, you know, what your counterparts are doing or problem solving together and new approaches to things. But it's also, I think, you know, back to this idea of compassion fatigue and how do we as a system care for ourselves and each other. You need those moments of inspiration and those partners that can say like, oh, I get it, I've been there. And then I talked to this person and I have this new energy. You know, it's always a good kind of conference or event when you leave sort of newly committed to, newly inspired and better equipped to do the really important and great work that you're all doing. Marisol, you mentioned, you know, thinking about your nephews and then your generation and your parents and so on, and that intergenerational kind of echo of trauma and risk is so important. And I just want to mention a video that probably some of you have seen. It's on YouTube, called Step Inside the Circle. And it's in a prison setting, but looking at the impact of trauma and intergenerational trauma in particular. In this case, it's a group of men. It's a really powerful video. I always like to say, though, this is shown in a prison setting, but it could be also in the lunchroom of a big corporation, or, you know, a college, or, you know, a lot for these forms of trauma don't discriminate. And I sometimes actually worry that because it's in a prison setting, it's sort of reinforcing that stigma. But I think when sort of framed and delivered appropriately, it's a really, really powerful video. And just for me, a really helpful reminder. Yes, I will try to pull up a link and put it in the chat, because it's definitely worth a view. And I will
And
do that
then
live.
Lynn also had her hand raised.
I just want to thank Vanessa for talking about the stigma kind of being erased when it was a personal experience. And I think that's going to help us change that norm, that social norm, because so many people now have a personal experience associated with substance use, misuse, abuse, whichever term we use. And I think that that's going to help us all to decrease the stigma, because I think there is so much more of a personal relationship to this topic.
Are there any other questions or comments on this subject? I'm happy that you asked, Lynn, because like Marisol, I think the Inspire to Rise presentation was definitely one I was happy to be able to watch and listen to. You know, I've been involved in a lot of volunteer work with parenting and children, as well as recovery. And, you know, when I first started, ACEs were more under that parenting program and hadn't really like gone over into the recovery side yet. And in my brain, I was like, how do we get these two together? Because that's where the prevention will come from. So I am very, very happy to see, like, you know, all the talk about ACEs and the protective factors, and the way that Inspired to Rise just kind of built their program on the protective factors. And it seemed like they used those as their like foundation before doing anything else. If I had to guess, they were like, how do we make a program that fits this? And it was really, really cool to watch how they created their program in that way, because those protective factors really will, you know, turn, like Sarah had mentioned, they will turn that, you know, adverse childhood experience into a positive experience, you know, being able to watch the resilience from, you know, the parents, being able to watch how social connection is used and how concrete support is used. It'll be amazing that our generation gets to see that today. And I'm so excited that my kids are growing up in this generation and that they can see it. Is there any other questions or comments on this question before we move on to another?
I'll just quickly mention, Jordan, that I put a link in the chat to our strategic plan for ACEs, and it includes a lot of links to a prevention resource and other kind of communications materials. Of course, I'm completely biased because most of my work does focus on ACEs, but I landed here after a lifetime of work, first in violence prevention and then overdose prevention. And actually worked with the Overdose Data to Action Award up until about 2 years ago. And to me, when you take everything that we're talking about and kind of follow it back to its roots, you land on ACEs, which means that when we prevent ACEs or mitigate the impact of ACEs, we are addressing all of these things. So yeah, please check out that link. And I also linked to the Step Inside the Circle video as well. It's that very odd looking YouTube link that I posted.
Thank you so much. We've got about like 10 minutes left. So I really want to make sure we get to this question here, because I'd love to hear from everybody on this one for sure, because we'd only learn by, you know, listening. What will it take for the culture of stigma to be changed?
I will start with that while everyone gets their hands raised. And I really definitely feel like you all have a lot more valuable insight than I have, but I'm a talker. So I think, I used the words persistent and relentless and comprehensive a couple of times in this discussion. And I think that stigma is so woven into the fabric of our society that we have to dismantle that. So, like Vanessa mentioned, it's about our data systems, and like Lynn's been talking about, it's our healthcare systems, it's our school systems. I mean, it's every system. You wouldn't even think about it, but it's our banking systems and how we finance our lives and all of that. It is baked into our way of doing. So we have to get serious about a bottom up and top down and left to right comprehensive approach and relentlessly pushing back. It's so insidious that I think even those of us that are really paying attention to it on a constant basis still miss some of the little like jabs of stigma that are here and there. And I think we can use science, communications, and behavioral science to start dismantling that, to first make people aware of the extent to which stigma informs, what we as a community and culture and society are willing to do, and how to support people that are struggling with the disease of addiction, and then go from there. But I think it's going to have to start first with awareness. But like I said, I think you all have a much better kind of on the ground sense of what this work actually has to look like. And so I want to tack on to Jordan's question of what do we have to do? And also how can CDC help? What are some resources or insights or venues that we can help generate to be a part of that?
We did have in the chat, Arthur said, as a community organizer, one of the biggest pieces is before we talk about stigma, especially discussing how it's passed down across generations, we have to start with an understanding that these behaviors are based on communities learning to navigate and survive the very racist systems in place: criminal, child welfare, healthcare, mental health, and others. Seeking help often meant our grandparents would be institutionalized, have their children taken from them, would be ostracized, etc. And similarly, when we talk about intergenerational trauma, we have to focus on intergenerational healing. Yes.
That is a mouthful, to be sure. And I think it's critical to name it, to thank you for naming it. Every single institution that I mentioned and all of the others that I didn't mention were built explicitly to protect the interests of white people. And so there is a true dismantling that has to happen. I think, that is a generation's work, but it starts with naming it and recognizing that, and then building the will to dismantle and rebuild. Thank you for calling that out. Other thoughts? I know you all have some great insight from your experience on this. What do we need to do to address stigma? Where do we start?
Deja has her hand raised.
So one thing is here in Clay County, right? It's very, we have what we call Fleming Island, right? It's more of like the newer upper class area. And people there living in the area don't think that overdoses happen in their community. They're like, oh, that doesn't happen here. It's like, well, it does actually. It could happen at your neighbor's house. And I think that's really what it is. It's people forget that addiction doesn't just happen to the lower class or the minorities or whatever it be. It doesn't discriminate. So I think it's important to let people know who maybe don't, who are ignorant to the topic, that it can happen to anyone, no matter how much money you have, no matter what color your skin is, no matter your cultural background, your educational background. It can happen to anyone. And I think that's something that people need to know.
Absolutely, such a critical point. And I think, it takes such an immense amount of courage to be willing to sort of defy the stigma and the shame, and to name it. But you're right that in certain, particularly among higher SES, it's easier to conceal. When you can, someone, they're not in treatment, they're at a spa. And really, I mean, that's, I know, a little bit sort of trivializing, but that happens. And there's a certain almost like glorification of the therapeutic approaches to managing what is ultimately a disease that does affect everyone, regardless. And I think that's important for us to keep top of mind as well. And I think the opioid and now really polysubstance epidemic has forced us into a more kind of on the table recognition of that, which ultimately is necessary. It was, an incredibly painful process and still ongoing, but it is sort of pulling the curtain on that a little bit.
We did have in the chat, we need really great social media campaigns to target youth. Absolutely, for sure. And then we had another, Vanessa in the chat said, start dismantling stigma by calling it out within ourselves and among our friends, families, and colleagues, which reminds me of like that recover out loud hashtag that's going around on social media right now.
That's a great one, but it's so true. I think we all have to be willing to, we're gonna get it wrong sometimes, but I think if we sort of honor the striving, but also hold each other and ourselves accountable to do better, you're right, we can kind of lead the way and model that.
It's almost time. Does anybody else have any last questions or comments that they want to share before we end? All righty. Oh, go ahead.
I just want to thank you all so much for taking the time and more important, for the work that you do. It is seen and appreciated. So thank you all.
Thank you. Especially for sharing your experience on the subject of stigma today. This was very interesting. I'm very excited that we had this discussion. Attendees, please make sure you use the link in the chat to complete the evaluation survey for this session. Thank you to the Florida State University for managing the summit evaluations, and all of you for participating and making this interactive discussion possible. Please make sure you go to your summit program PDF or visit thepathforhope.com/summit 2021 and click on the link for the next session that you would like to attend. And now I'll be ending the meeting. Thank you guys so much.
Bye, everyone. Have a great day.